Sorry about the forced platform. I lugged a 20-kilo lump of metal over, and then I don't know what happened. I was up at midnight last night trying to reinstall software. So that's sad, because I brought it last time and it's quite fun. So like I said in the email, maybe you should have one of these in Perth next time. We have an island 20 minutes offshore called Rottnest. Cheap accommodation. You might end up you could be in a tent being attacked by quokkas. That's part of the fun. So yeah, and then pop up north to see the whale sharks, Exmouth. Has anyone seen the whale sharks? And if you can't swim, they just chuck you in like a floaty thing and they drag you along. Okay, actual questions?
Yes, we've been swimming with whale sharks. Magnificent experience. Can recommend it to anybody. And you don't have to worry about them eating you, because then they just get out of your way.
Okay, so I wanted to ask a question. Does anyone think drugs are completely useless? Has anyone had like no joy with drugs? Oh, that's different. So anyone who's tried a medication for OT has had some even small benefit. That's good to know. Who here does not do any non-drug approaches? So if you have, do you exercise or do Pilates or Tai Chi or some balance thing or whatever, the Falls Clinic? Yeah. Scar will tell you about it. If you don't, then you don't do as well. Yep.
Julian, at our first conference...
Microphone. Just wait for the mic, see?
At our first conference, you started off by saying, here's the good news. This is a progressive disorder, but none of you is going to die from it, as compared with some other tremors.
Paraphrasing again.
Yeah. And then he said, yeah, all right, I'm sorry about this. I'm getting older, my memory is not so good. But the other thing I think I remember you saying is that basically this is an embuggerance you have to learn to manage.
Actually, it's all on video, you're probably right.
Yeah, but anyway, the thing is, I think for me, I remember that, and those of us who've met and talked about it since agree it's an embuggerance and we have to learn to manage. And there are ways of managing it. We're not going to, none of us expect to get back to perfection. We don't expect to be as glorious as we were when we were younger and pre-tremor. But you can manage it. And so it's the question of the drugs and the other aids and the other therapies are all part of the management thing. Now, have you changed your view on that?
What have I done? No. So I didn't show all the non-drug slides I did last time with that. So the stick that turns into a fold-out chair. So walking aids, / confidence aids, even like a stick if you hold it, sometimes is enough. The physical therapies, I don't use anything complementary because it's hard enough as it is with the medical stuff. I just used Falls Clinics, physiotherapists, and the goal there is specific, so like strengthening, whatever else you might like to call it, core strength, and don't want to talk about, he's got to give a talk, so I don't think. What's the other thing, physios and other therapists? Yeah, any other joint pains. If you have a bung knee, so I hate the word holistic because it just applies to other things. Anyway, so you must look at all these things. The drugs is my job to like make sure we're not poisoning people, because someone who's 65 and on a bucket full of Lyrica might be doing great, but then now they're 75, and I've just been ignoring the fact that they're, cognitive impact and things like that. So, so I see people every 6 months, mainly to just write another repeat script, but also to just check them, that sort of thing. And I do the standing time, monitor that, and bug them about, are you still going to the physio? And most people are very motivated. But despite that, it is progressive, and I'll see people come in. And there's one guy that's still everywhere, and he's nearly 80, and he just keeps coming in lower and lower and lower. Like, how are you going? Okay. All right. I've been adding medications to him, but he's not been tolerating them, and I will probably get him to try Perampanel, but I'll probably put him in hospital just to get some rehab as well. So no, I haven't changed my approach, and I'm open-minded as long as nothing's dangerous. I would.
Are you open-minded about diet? The reason I say that is being on gabapentin for a long time, I put on a lot of weight, which of course, as everyone knows, makes moving difficult. I go to Pilates twice a week, walk every day. And I found through a girlfriend, a nutritionist, and I'm not flogging any programs or anything like that, I'm just saying what's worked for me. And I've been eating keto diet, and as well as losing the weight and keeping it off, not just losing it and gaining it, keeping it off. My husband said to me, you realise you haven't had a bad day since you've started this program. And I look back and I went, no, I haven't, because there are days when it's, you know, hard to get out of bed, got to lift your legs out, you just have a shit day, sorry, a bad day. You know,
I think we should all swear more often.
What am I doing? But I just thought, if anyone wants to talk to me about it, I'm happy. But I really feel, and the nutritionist that I worked scientifically with a New Zealand hospital with MS patients, and it's not to cure, don't get me wrong, it alleviates inflammation in your body and a whole lot of other things, and they had incredible results with MS patients, which is very new. And I'm just thinking, it's helped me a lot. I'd done a step up that I was worse. I thought, here we go, progression, and now I'm not even needing a stick to get around. I'm not saying it's just the keto. I'm just saying the losing the weight and watching what I've eaten, Pilates, has dropped me. Instead of going up a step again, I've gone back to how I was probably.
I actually have something to say about that.
Yeah.
I'll wait for the microphone.
You've got a whole session.
I do, but it is a timely topic. So the whole thing about the diet, doing the exercise, doing physical therapy, all of those things, that's part of your care team. So that's a fantastic thing to do. So some people come to me and they'll be like, oh, I've got this wrong with me. So they'll just rely on the sessions and their exercise prescription. It's more. It's what you take. Sometimes it takes a psychologist, dietitian, the neurologist, all the different input of all the different people help to create the better outcome. So I think you're onto the right thing there, just articulating that it's a team approach.
So as far as ketogenic diet goes, there is no evidence. And I'm just saying, I don't try and I just go, I don't know nothing. Please go away and try it and come back and educate me. The only thing that ketogenic diets have evidence for in neurology is epilepsy, some types of epilepsy, and it's the hardcore ketogenic diet, but there's lots of anecdotal stuff about just energy and ketogenic and other stuff. Yeah, and stopping having the sugar swings. Do you monitor your blood sugar and keto sticks? Is your BSL flat? Ish? Because you got to keep it in that flat range, and then you see all these wild changes with ketones, which are really interesting. And my ex-PhD supervisor has a website, 6xc.com.au, check it out. So he's an ex-neuroscientist, and he swears that he obsessively has monitored his, because he's a scientist, ketones go up and down, and he can track it with when he does lots of cognitive workload. So obviously if you're cognitively a bit shot and fatigued, you're not going to perform well with your chronic neurological condition. So yeah, I don't think it's not unreasonable.
What is keto?
You got to cut down to 10% carbs, which is insanely difficult. You can do like a less strict one, 20%, and the rest is fat and protein. It's actually really it's good. Meat, fat, and so I've been I'll put it this way: eat more curry, less rice. Have the stir fry, not the noodles. More meat, less pasta. That sort of. Yes.
When you have an operation and you have anaesthetic, should that affect the drugs that you're on and make you feel worse? I've had an operation 10 days ago, and I've gone downhill.
Well,
within a couple
in general,
of days.
the stress of surgery Stress of surgery
So it's
includes...
not actually the anaesthetic itself, it's
the
the
whole
stress.
surgery itself.
The stress.
Speaking holistically again, surgery is a big stress. They put you to sleep and then they operate on you, and then
Yes.
the drugs go in and drugs go out, and then you have stress hormones released and all sorts of stuff. You know, I'm not an anaesthetist, but I see lots of people with chronic conditions who have a step down when they have surgery, and then they'll gradually come back.
Yeah, it does come back, but it's
and
sort of
and
gone
some
down
patients
to...
who have a progressive disorder like Parkinson's, where they'll have some big stress, end up in ICU, and then they never make it back to where they were before.
Okay.
So surgery is not...
So it's not the anaesthetic, it's the stress of the surgery.
It's everything.
Okay.
Yeah.
Okay.
Ask Adam more questions.
Dr. Rodrigues, I asked Dr. Pav if this is permanent, and he said yes and no, because there's so many new drugs coming out that it might not be permanent.
Maybe he means that he's hopeful of a more successful treatment.
Yeah. So if you're applying
I can't
for
speak for Shav.
I know, I
Shav?
call him
Shav.
I know.
I can't say his last name either, just call him Shav. So Shav, I'm sure he means that he's hopeful he'll find something useful.
Oh, he's wonderful. He's just like you.
Thank you.
If you apply for the, what do they call it, disability scheme,
Yeah.
would,
NDIS, yeah.
would they put permanent on that?
Yeah.
Yeah.
So in general, when I'm filling out forms for disability, I get the person in front of me and I go, what do you want me to write? Within reason. And you make the person sound completely useless. And then if you have a good day, that's fine. But if you're having a really bad day, then that should be the level of support that you're offered. So there.
Okay. He's wonderful anyway.
I'll tell him.
Have you had any feedback or any knowledge of LDN, low-dose naltrexone?
No.
No?
Was that you that was saying before?
No, it wasn't me,
right,
but
okay.
somebody else might have, because we're getting some
Where's
reports.
that from? I've seen people on it for other things.
It's usually for opiate withdrawal.
No, something else. Can't remember what now. Useful?
Two women in the States have had great success with it. So
For orthostatic tremor.
for orthostatic tremor in particular, and so I've decided to give it a go.
Can I make a plea for anyone who's going to try a new thing? Can you please go back to your neurologist and go, can you test me? Or my physio, do some standing time,
Yes.
some objective measures, do what scales do you use for confidence? There's that activities balance confidence scale. There's some other fear of falling scales and quality of life. Do all that, and then at the end of the day, if your quality of life and function is better, who cares what the cause is or what the mechanism is? But yeah, and then because that's the problem with blogs and things. You can get someone with an excellent response, but you don't know what that means. So if you can do a little data set, and then at these meetings you can put up your little poster, like I do at the conferences. Yeah.
I can notice for me that I can still do a lot. I go to Zumba, and although Zumba, which is an hour of vigorous exercise, dancing exercise, and despite the fact that I am legally blind, my vision allows me to play table tennis just within the width of the table tennis, and I can do that now only for an hour, whereas I used to be able to do it for a couple of hours, and I notice it's as I age. So I don't know if it's that I'm aging that's making it harder, or is the OT progressing?
OT is generally progressive.
Progressing.
Not linear, but and yes, additional problems, aging related, can impact. You know, knee arthritis, deconditioning from not walking. But there's definitely a progressive element to it. It's just quite slow over decades.
Falling over, turning your leg like I did.
Yeah, having a fall, that'll set you back.
Oh, okay. I just want to share my story. I've recently, in the last 3 months, tried the Ficompa. I've been very happy with it. I no longer claw the floor. I can navigate around a gift shop. I can stand at the checkout at the supermarket. I can do all these things that I couldn't do previously. The anxiousness isn't there. The downside to it all was I got very depressed. So I went off to the doctor. I decided to go to a psychologist, went and had 6 sessions with her, went back to the neurologist. He suggested that I go on antidepressants. We've all got a thing about antidepressants. Anybody that takes them, oh, they're on that, oh, they're no good. Anyway, I tried them and I feel wonderful. So, there's nothing wrong with taking the antidepressants. I feel like a new woman. I'm smiling again. For a long time I wasn't smiling because I was so negative on everything. I was very angry with the Ficompa, but since I've been taking the antidepressants, like I said, I take 4 milligrams, is it? Yeah, of Ficompa. So that's just my story. And I'll continue, to take them. But I just feel like I've had the Tremor for 15 years. I've tried gabapentin, clopazepam, Topamax. So I've had a good run with all the drugs. But this one at the moment, I just hope it keeps on going as well as what it is. So about 3 months. So I started off on 2, then went to the 4. But yeah, no.
Can I just ask, were you a responder to other medications?
Yes. I found...
But this is better?
This is better. It's a lot better. 100%, well not 100%. I felt results within the first week of being on it. And then it sort of... I think I felt like I was overdoing. I had the cloudy head and everything and I was getting a bit of headaches. But I've actually had more, I can't think of the word, like the memories like everybody else's.
Word finding difficulties.
Well, I felt going on the depressions, I got more fog in my head. My head was very foggy for a week to start off with, and I felt good, but I started on 5 and then went to 10.
That's the Telegram.
Yes. So, but, since taking that...
So, sorry to interrupt. This is how I learn stuff. So I would normally not accept a side effect of depression. So weight gain I never do. I ask people to diet, but then if it's going up. So, but mood change is really common with all these anti-epileptic drugs. I see it in migraine as well. And I would normally say it's not acceptable, you have to stop it. But now you're saying that you treated the side effect of one drug with another drug and it's worked out well for you.
Yep.
See, I do that in Parkinson's all the time because people have to be on dopamine. If they get a side effect from the dopamine, then you can't not do dopamine because they'll be in a wheelchair.
Well,
so
my
I'm
doctor's...
constantly treating side effects of other drugs with other drugs, and maybe...
Well, my doctor's Dr. Shav as well, and his response to the depression was, no, just go and get some... No, get the depressants. Don't worry about the other. Get them. That'll fix you. If it's working for you, take it. And that's what he said.
So he's a champion for Parampana, going, no, just stay on it and just treat the depression. So
yep,
that worked out really well.
Yep, so no, I'm very happy. So thank you very much.
Who was it that had depression and stopped it here? There you go.
I probably know the answer to this question, but I'm just wondering, there was a bit of publicity recently about MRI-guided focused ultrasound.
Yeah.
Now, I'm assuming it's no good for OT because you have to stand, but...
No, problem is you can only do one side. So we had our annual brain stimulators meeting in Sydney. Sounds weird. But all the surgeons and neurologists and nurses were all there. And Ben and Steve, who do it in Sydney, presented their data on hand tremor, and it's wonderful for that. But you can't do both sides of the brain because the risk of permanent side effects on balance is unacceptable. Probably about 20% chance you'll actually be unsteady.
So no good for
Yeah,
OT.
you can't, because it sounds like new tech, but it's a new way of doing an old operation, which is lesioning the brain. So there's a bit of the brain will allow you to lesion certain pathways on one side, but if you lesion both sides, then it loses its backup. And,
I've got a question. We talk about shaky legs. What about shaky arms? Why are they?
Well, so the tremor, that hypothetical tremor generator is somewhere above the brainstem, somewhere below the cortex, and it obviously maps out to all body parts, so it just doesn't manifest. But in some people there can be a subclinical tremor that you can measure in the hands, particularly if you push on something.
Yeah, it's
some
weight bearing.
Yep. And some people, there's even reports of it being in the head in some people. So I've tried to record it in some people, and sometimes it's half the frequency, like 8 hertz. But either way, some people have a hand tremor, and that lady up there who was switched from gabapentin to pregabalin, her hand tremor, she was very pleased because pregabalin helped a lot with that, in addition to her balance.
I think we'll have to make this the last question because it's getting into Adam's time. So.
I won't keep you. I am on clonazepam, but I was on it years ago, as I said to you, to have my children because I had to come off Epilim. And when I came off it, after 16 years, I was like a drug addict, and I was sick for 2 years. And my then doctor told me, not neurologist, go out and sit in the sun. Well, that was bullshit. Sorry.
Never mind the melanoma.
Sorry. And anyway, I ended up going to Dr. Pav.
Shav.
And
Shav Pav.
Yeah, well, my angel. And he put me back on, after I went on Epilim, and then he put me back on clonazepam, where now he's about to slowly wean me off it and put the new drug on.
Yeah, if he's got someone else on it, then
yeah.
I have to look his name
I just
up.
wondered if anybody else had that.
So yeah, benzodiazepines can cause tolerance, and then when you stop them, you feel awful. Not normally for 2 years though, and you would just wean off a bit slower. And so yes, you obviously have withdrawal. I start people on 0.25 milligrams in the morning. If they only get a bit sleepy, I say hang in there, because after a week you might be tolerating it, and you may or may not get a benefit of that dose. And then I go 0.5 milligram morning and then lunchtime. Take one in the evening if you like it, and it's working well. Yeah, 0.5, and people get up to usually. So the maximum daily dose is 6 milligrams, say for epilepsy. But most people can't tolerate that with tremor syndromes. 3 milligrams a day would be the most.
Okay.
Shav, Parasivanan. Sharavanan, Parasivan. It's not that hard.
There. Got that out of the way.
I want you to, next time you see him, just say, hello, Dr. Parashivan. But even on his website, look how handsome he is, look at him. Even on his website he says, Dr. Sharavanan and Parasivan, Shav, completed his degree.
Okay, I think we need to bring this session to a close on that note, and please join with me in thanking Julian very much.